Okay, perfect. Good afternoon, everyone, and thank you for joining us for another one of our free MAG educational seminars. Today we have the lovely Dr. Lara Wetton, Cosmetic and Aesthetic Procedures Specialist, and the session today is about body dysmorphic disorder in cosmetic surgery. Most of you will have heard of plastic and reconstructive surgeons. Dr. Wetton here works on cosmetic and aesthetic procedures that make us feel better about ourselves, which is why they can be so contentious in the medico-legal space. The lovely Dr. Lara Wetton will be explaining the differences between plastic and reconstructive surgeons and cosmetic and aesthetic specialists, and the types of medical negligence that can occur with cosmetic and aesthetic procedures in the August issue of MAG's Medical Negligence newsletter, which goes live later this month. But today she's specifically going to be talking about body dysmorphic disorder in cosmetic surgery. Okay, so I see that our person has been muted, but if anybody else comes throughout this, just please make sure that you all remain on mute so that noise from your home or workplace does not affect the quality of the recording. You will be able to unmute and ask questions at the end of the presentation, or you can type your questions in the chat if you need to or don't want to speak up. The recording will be sent out to you within a day or so, along with the slides. Now, without further ado, I will hand you over to our speaker today, Dr. Wetton. Over to you.
Thank you so much for the kind introduction, Taylor. So today I'm going to talk about body dysmorphic disorder in cosmetic surgery. A bit about me. I'm a fellow of the Australasian College of Cosmetic Surgery and Medicine, which is the only college which specifically trains fellows in aesthetic procedures of surgical and non-surgical. I sat the written examination of the American Board of Cosmetic Surgery, and I've been active in the industry for about 14 years. I'm also on the council of our college. I'm the COSMETEX Convenor, which is our annual cosmetic conference, and I've also run Journal Club in the past for our fellows. I'm also a reviewer of an international aesthetic journal, and I have a private practice in Double Bay where I perform surgery about 70% and medicine about 20% in the aesthetic sphere. So what is BDD? It's a psychiatric disorder characterized by a preoccupation with an imagined defect in physical appearance or a distorted perception of one's body image. So according to the DSM criteria, it's a preoccupation with one or more perceived defects or flaws in physical appearance that are not observable or appear slight to others. It's repetitive behaviors such as mirror checking, excessive grooming, such as swishing their hair or skin picking. They seek reassurance from others, and they can sometimes compare their own appearance with that of others. They also have a preoccupation causing clinically significant distress or impairment in their social or occupational function or in other areas of their lives. And they're preoccupied with their appearance, and it's not better explained by concerns with body image related to excess abdominal fat or weight, excess weight. So it is not an eating disorder. My slides have frozen for some reason. That's funny. Sorry about that. Nope. How odd. Okay. Let's just see what's going on. There we go. So body dysmorphia in the cosmetic industry is quite rare, and it's a perception which obviously we know is discordant with reality, and it can fly under the radar sometimes, and we can only realize that a patient has BDD once we've already operated on them, which is quite unfortunate. It's important to avoid operating on these patients because they often have unrealistic expectations of what they're going to look like afterwards, and then they require or demand some corrective surgery, and after this, again, they are usually not satisfied. So this whole process can be quite traumatic and devastating, not only for the patient, but also for the doctor, and it can have some devastating consequences. So it's important for us to know how these patients present in clinic, and through experience, we can start to understand how they present. So patients often present in clinic in different ways. It might be obvious that they've got a distorted body image and they've had many previous aesthetic procedures, but it may not be apparent at all, in which case it is quite difficult to determine if these patients do in fact have BDD. So I'm not sure if you're aware, but APRA has released cosmetic guidelines last year, the 1st of July, 2023. And we were all in our college very excited for this progress to protect patients from aesthetic procedures which may be deleterious to their well-being. So some of these guidelines are, for example, all patients seeking cosmetic surgery should have a GP referral. Another one is a medical practitioner who performing the surgery must discuss and assess the patient's reasons and their motivation behind their desire to have the surgery. They should also be asked if another practitioner has declined to operate on them, because this might give us a bit of a clue. Perhaps they're not suitable for this procedure. The medical practitioner who will perform the surgery must assess the patient for any underlying psychological conditions, such as body dysmorphic disorder or BDD, which may make them an unsuitable candidate for the surgery. So the practitioner doing the assessment must use a validated psychological screening tool to screen for BDD. The process and the outcome of the assessment and screening should be documented in the patient's notes. So we've started to do this in clinic all around Australia, and I think it's definitely benefiting patients. Another one of their guidelines is if screening indicates that the patient has significant underlying psychological issues which make them unsuitable, they should be referred for an evaluation to a psychiatrist or a psychologist or a general practitioner who works independently of the medical practitioner who will be performing their surgery. And the medical practitioner should also discuss other options with the patient which don't include surgery, in case this might be a better option for the particular patient. And the medical practitioner must decline to perform surgery if they believe that it is not in the best interests of the patient. So there are many tools available to assess a patient for BDD. For example, the BDD questionnaire, the dermatology version, which has been found to have a really high sensitivity of 100% and a high specificity as well of 89%. There's the dysmorphic concern questionnaire, there's the Yale-Brown scale, there's the body dysmorphic symptom scale. But in reality, BDD patients are pretty smart and they can detect that you're trying to screen them out. So they may not always be honest on these screening tools. Also, it's important to understand that many cosmetic patients are a little embarrassed when they may be seeking cosmetic surgery, and perhaps they've really plucked up all the courage they have to go and have an assessment by a practitioner for an aesthetic procedure. So it's important for us not to intimidate them or make them feel scrutinized. So that's the reason why I've chosen the dermatology version in my practice. And I actually have a disclaimer at the top to say this is one of the guidelines, which is important that we all follow, and that I'm not individually picking on patients to make them feel self-conscious. Another reason why I chose this one for my practice is because the first question basically screens out patients who don't have any inclination to have BDD. And so then these patients can move on with a consultation without being overwhelmed with too many questions. So this is the example that I use. The first question is basically just saying, are you worried about how you look? Now, you would think that pretty much all patients who come for aesthetic consultations would say they are worried about how they look, but some of them are not that concerned. They just want to say, stay the way they are or prolong their youth or things like that. Some of the other questions that patients then continue with is their main concern that they're not too thin or too fat. So this is important also to screen out those who may be inclined to have anorexia or bulimia. And then how is this problem and how is it affecting your life? And then how has it gotten away with your general activity? How has it got in the way of your general activities? And then finally, we can score them in terms of how often they think about this problem. Are they preoccupied with it many hours of the day, or is it just something that comes through their mind on and off? So there has also been a body dysmorphic disorder questionnaire specifically for aesthetic surgery, which has been made. This is a 7-item short questionnaire. Its sensitivity is 89.6% and its specificity is 81.4%. These patients who score positive on this scale have been found to be more impaired in daily life and experience more appearance-related distress and dysfunction compared with those who don't score highly on this scale. They also had more severe symptoms of BDD, and BDD positive patients were less satisfied after surgery compared to patients who score negatively on this scale. This scale was specifically made actually for aesthetic rhinoplasty patients. And it is as follows. So question 1 is, again, are you worried about your appearance? Does these concerns preoccupy you? Yes or no? And then basically a scale. Do these concerns cause you a lot of distress or torment? And they can say no, not at all, or extreme disabling. Do these concerns impair your function, again, in your ADLs? And then, of course, just grading them on these scales. Are there things you avoid because of these concerns? So that's basically the aesthetic scale, but it's a bit longer and it's a bit more scrutinizing for aesthetic patients. So some of the red flags that we might start to notice in our clinics when we see aesthetic patients are that perhaps it's visually obvious that the patient has had multiple cosmetic procedures in the past, or it may come up on clinical history. They may look to be that they've not had anything, but then when you talk to them a bit more, you may find out more. Obviously, another one is they may score highly on the BDD screening tool, and then obviously that's a red flag. In the consultation, they may be obviously preoccupied with an aspect of their appearance, which you as the clinician don't see, or either don't think it's that big a deal or that obvious. So they might be preoccupied with, say, a lump on their nose, but to you, it's hardly a lump at all, and they're just really fussing over this lump. They may also describe how this defect controls their life, and they may place a huge amount of emphasis on it and its need for correction. They may also be really pushy and determined to get their way, sometimes even quite rude. And if you question the appropriateness of a particular procedure or treatment, or even question their mental state, they might get quite abrasive. So in clinic, BDD patients tend to be quite shy, often quite young, sometimes depressed. They tend to be socially isolated, partly because of their real or imagined physical flaw that they have, that they feel too self-conscious to go out in public. And at times they describe themselves in derogatory terms. They might say that they're really ugly, or they feel awful or disgusting, which is quite sad to hear this coming from a patient. It's important for us to resist the temptation to operate, even if we see where they're coming from, but their perception is over-dramatized. So often we can be so empathetic, we think, oh, I must put this patient out of their misery. But in actual fact, we're doing more harm by operating on a patient like this. So over-enthusiastic patients who've had multiple procedures by other surgeons and are planning to have many, many more, they might talk to you about a list of procedures they want. That's definitely important to note. And they might be dissatisfied and have a history of attempted retaliation against a doctor who they believe has perhaps worsened their defect. And sometimes they refer to this as that doctor has ruined my life. I've known BDD patients to be physically threatening. They at times take legal action. And I've even witnessed a patient giving some death threats to an aesthetic practitioner. So that's pretty scary. I just wanted to talk you through a couple of cases that I've seen myself, just to give a few examples of how these patients present and what the clinical sequelae might be. So I had a patient come in to see me. She was 29 years old. She was a female and originally from Pakistan. So obviously she had Fitzpatrick type 4 skin type. She was unemployed currently, but she was at TAFE studying and she lived with her parents. So in the consult, she said to me, she's come to see me because her chin is too recessed and it is too small. She wants to have a chin implant. And she also feels that her skin is not smooth and she wants to have laser resurfacing to refresh her skin. So her past medical history and surgical history was quite unremarkable. She just had acne as a teenager. She had been on Roaccutane for a year or so, and she'd never had a cosmetic surgery. She'd had cosmetic dermal lip filler injections, but nothing else. I did ask her some leading questions, and it came out that she doesn't socialize because of how she looks. She's really self-conscious, and she says that she can't apply for a job until she has the surgery, and then she hopes to look better. She did score borderline on my BDD scale. So my assessment, in terms of her affect, she looked quite depressed. She was shy. She was unable to give me eye contact. My assessment was that although she'd never had surgery and she'd never had many cosmetic procedures, I explained to her that her skin type was not appropriate for laser resurfacing because she might suffer from hypo or hyperpigmentation, which might be devastating in the long run. She did actually have a reasonably recessed chin, and I could see what she was talking about. But in my eyes, I didn't think that this should prevent her from, say, applying for a job or going out with her friends. I was concerned, so I wrote to her GP to determine his assessment and her general mental health status. And I found out that she had bipolar disorder and was on a mental health plan, which she failed to disclose to me during the consultation. She did call the clinic multiple times to try to book in surgery. And I finally told her that she had not been honest with me regarding her mental health status. And so I could not consider surgery because our relationship had not been based on trust. She was annoyed, but I didn't hear anything further from her. I don't know if she did get this procedure by another aesthetic practitioner. Oops. Case 2 was a Caucasian 22-year-old young girl. She had green eyes, blonde hair. She had a perfectly shaped face, and she was a beautiful girl. She seemed quite calm. She talked to me openly. She did not seem too bothered by her appearance and was not concerned about previous aesthetic procedures. And she said to me she was reasonably happy with all the surgeries that she'd had previously. Again, she scored moderate on my BDD assessment tool. So upon history, I found out that she had had a few surgical procedures done. She'd seen a couple of plastic surgeons in Sydney who'd agreed to operate on her. She had a buccal fat pad removal and a chin implant. And then 6 months ago, she'd gone to Thailand for an upper eyelid blepharoplasty. When I looked at her face, I saw that the scar was much too high and was quite disfiguring her upper face. It was a huge, long cut. I was quite shocked at the result, yet this patient didn't seem too concerned about it. She also had some cheek fillers performed in the past, and she had very obvious symmetrical freckle tattoos all over her cheeks. She came to me requesting a facelift and liposuction of her submental area, and I thought this was quite odd because she didn't have ptotic tissues at her age, and she didn't have much fat either. So in my assessment, I basically did tell her that she's not appropriate for the procedure that she's requesting. And I did question her judgment in terms of the previous procedures, but obviously I didn't want her to feel more awkward. So I just told her that it wouldn't be a good idea for her to go ahead with this surgery. The final patient was a 38-year-old male, and this was actually happening during my training, so I wasn't the primary operator. He was of Afghani origin, but he migrated to Australia about 10 years previously, and he worked in a car yard. His cosmetic surgical history was interesting. He had spent 2 years in Egypt, where he went for to have the Elizarov technique. So I'm not sure if you're aware of this, but this is a leg lengthening surgery, which is quite painful. And it can extend the length of your legs by a few centimeters to make you taller, if that's what you desire. So he wasn't happy, obviously, with the length of his legs before he went, but afterwards he was quite happy that his legs had, grown a few centimeters. And then he came to Sydney for calf implants because he felt that his calves were now too small and too thin and underformed. So I'm not sure how he scored on the BDD assessment tool because I didn't have these results, but the surgeon did perform a bilateral calf implant, and the patient then incessantly called the rooms over the next month. He was not happy with the result. He just found fault with everything, but he had no complications and he had a pleasing outcome and he healed really well. Despite this, though, he wound up in the emergency department having a mental health crisis, and eventually I think he took legal action. It was a bit of a disaster for this patient and for the operating surgeon. So there are a few avenues that we can take as practitioners if we are presented with a patient who does have BDD. So since we now require GP referral for all cosmetic surgery, one option, of course, is to refer the patient back to their GP and to seek some advice or to get some clarification or to raise your concerns with their treating GP. An issue that may result is that the GP might write back in support of the procedure, or the patient might get really angry and unhappy that you have contacted their GP again to clarify things. So this is one outcome. Another action that can be taken is you can refer the patient, obviously, to a psychiatrist or a psychologist with a special interest in BDD. Again, if you do involve a mental health care practitioner, the patient might get very angry, upset, disgruntled. They might leave you a negative review or threaten you in some way. And then what could actually happen if the psychiatrist or psychologist is in support of the procedure? I have heard of this before, where a surgical practitioner had questioned a patient's suitability, and the psychologist had said it would be a good idea for the patient to have the surgery. So then you're kind of in a stuck situation. You still want to refuse the patient, but then you're not backed up by another practitioner. A third option is to kindly decline, like I did in the second case, where I just said to her, I'm really sorry, you're not suitable for this procedure. And then the patient does go their own way. But the question remains then, will they get inappropriate surgery by another practitioner later down the track? And of course, if you refuse the patient a procedure, they might again be angry and upset that you're not willing to operate on them. Another tactic in years gone by, surgeons used to just make the cost hugely out of proportion for patients who they felt were not suitable. And it may have worked in the past, but now it's not such a good idea because patients do talk. Obviously, we've got social media, and most of our costs are actually on our website. So it's a bit odd if suddenly, you quadruple the price of a surgical procedure. So these are some of the sort of avenues you could go down if you're concerned about a patient. Some operators don't recognize that a patient might have BDD because it is quite difficult to diagnose. In a survey of 265 members of the American Society of Aesthetic Plastic Surgery, 84% of plastic surgeons reported that they had unknowingly operated on patients with BDD. So this is a huge proportion, which just goes to show often it's not very clear if your patient does have BDD. Some practitioners may not mind operating on a patient with BDD, and they may not consider it an absolute contraindication for surgery. I have read a few papers on this topic. And then, of course, you do unfortunately get doctors who want the work for financial gain and will just operate on patients, despite knowing that they may not be appropriate for the procedure. So it's interesting just to look at the cosmetic surgical patient at a glance, because they are very different to most other patients who are seeking medical treatments for health-related purposes. So a cosmetic patient might be any age or gender. They're generally psychologically quite vulnerable. But then isn't that all of us now with social media and unrealistic expectations in advertising? And of course, they strive to live up to these unrealistic expectations. Cosmetic patients might be vulnerable in other ways too. They might be going through a life change. For example, they've just had a milestone birthday, they've just turned 40 or 60, and they're starting to feel their age. Or they might be going through a divorce and wanting to find a younger partner, or they might have just moved from a different country or changing careers. Generally, in terms of aesthetic surgery, emotions are high prior to the procedure. Patients have a lot of anxiety, a lot of fear, a lot of stress, often a lot of anticipation, sometimes huge amounts of excitement, because generally they're not unwell. So this is like a bonus. They have a lot to gain, but then of course they have something to lose. And the operator has to be discerning. So it's so important for us to see the patients, spend enough time with them, get to know them, and really question, is this a procedure in the patient's best interests? Would they benefit? Would they do well? Would they heal well? Would they be happy afterwards? Something that I've been debating and writing some work on is the adequately prepared cosmetic surgical patient, because it's not a simple thing. So yes, we can rule out they don't have BDD, but then what is their mental health like? Do they have anxiety or depression or another psychiatric issue? And are they mentally prepared for a big change, both physically and then immediately in their lifestyle? Surgery is stressful and it may trigger anxiety and depression, or even a social phobia, if that's an underlying condition, because patients often don't want to go out while they're healing after the first sort of 3 to 4 days of surgery. And is the patient emotionally prepared? So in most instances in my practice, patients have actually thought about having a particular procedure for many years prior to coming to see me. They have done quite a lot of research, and at times they've seen many practitioners. So most times they do have their head around things. And then, are they physically healthy? So do they have any pre-existing conditions? Do they have chronic pain syndromes? Are they physically healthy enough to manage a recovery from their aesthetic procedure? So I usually do a lot of screening, blood tests, ultrasounds, etc., to determine this. And then, of course, the finances. So the surgery can at times cost quite a lot of money. And for example, breast augmentation, we know that breast implants are not lifetime devices. So at some point in the patient's lifetime, they will probably need a second procedure. And are they prepared for this? Will they be able to afford it? Of course, practically, can patients take enough time off work to recover? Even if you've done a beautiful procedure and they have all the post-operative instructions, if they're not willing to give themselves some time to recoup and recover after their procedure, they may suffer some consequences because of this. So it's very important. In the recovery period, it's important that they're not a carer to others and that they have a carer, at least in the 24 hours after their surgery, to look after them. Do they have a support network of family and friends who are not going to judge them for this procedure? I often get patients who are very concerned about their family and friends, and they don't want them to know about their procedure. This does hinder their recovery because they don't have anyone to talk to. They don't have anyone to support them and say, don't worry, you did this for whatever reason you did, we support you and you'll get through it, because I find that's really what patients need. And then finally, are the patient's expectations realistic? So informed consent is so important, and I always stress the complications of a procedure. And at times I do reveal the worst case scenario, not to scare them off, but just to really reiterate that it is possible. Although it's unlikely, it's important that they know about these. So I have quite a lengthy informed consent process with my patients to make sure they really understand the risks and complications and likely outcomes. So at times, this process might take 3 to 4 consultations to make sure that I'm satisfied that they have adequate understanding of what is going to occur and how they will look afterwards. I try to get them to explain things back to me so I can make sure that they do understand. And often it's useful for patients to bring a family friend, a family or someone they're close to who they don't mind being in their consultation, who then I can explain things to 2 people and they can discuss things afterwards. Always, 2 sets of ears is better than 1. These are my references for this talk. And finally, do you have any questions?
Thank you so much for that. Well, that was one of the most interesting seminars I think I've ever sat in on. I'm so glad I did. Yeah, so as Dr. Wetton said, if you have any questions, now is your time to unmute yourself and ask away. I know that it was such a very thorough talk and that you might not have any questions, but if you do, please feel free to unmute yourself now. If you are unable to unmute yourself or are uncomfortable, you can also type them in the chat and I'm more than happy to read them aloud. Okay, I'll give the people just a minute to maybe think of a question, but I actually do have a question from a solicitor who was unable to attend. And funnily enough, you kind of touched on some of the topics throughout your seminar, mostly just the 3rd case study that you had, as well as mentioning about difficulty to diagnose BDD. So their question was, how do you handle patients who present as perfectly eligible for cosmetic and aesthetic procedures, but after receiving their procedure then begin to present the traits of someone with BDD?
Unfortunately, that is a very difficult problem. And no matter how many screening tools or how many consultations we might have with them, there are a couple of patients who might get through the cracks. And then it is basically communication with the patient and their family, trying to remedy the situation, getting a second opinion from one of your colleagues. Often it's helpful to get the patient to see one of your colleagues and they can reiterate everything that you've said and that this is a normal outcome and they haven't got any complications and they're going to heal and they're going to be okay. Often that is helpful.
Perfect. Thank you for that answer. It is quite such a I could imagine how difficult it is. And it obviously puts both the patient and yourself in such a difficult situation.
Absolutely. It can be very challenging.
I can imagine. Well, thank you so much for that. We do need to wrap up here. Does anybody have any other questions? This is your last chance. Okay, no problem. Thank you so much for sharing your expertise with us today. And thank you so much for everyone who could make it here today. We appreciate you spending your time with us. The recording will be sent to you within a day or so. Other than that, have a great rest of your day, and we look forward to seeing you at our next seminar. Thank you so much, everyone.
Thank you.